Well, greetings everyone and welcome to the EKG case for the week of September 30th, 2013. This week we have yet another fantastic case that was sent in by a resident, an amazing pickup. This was sent by Dr. Tom Chung. Tom is a third-year emergency medicine resident at Western University, works out of the London Health Sciences Center in London, Ontario. Now, that's the place that I had a chance to visit recently, and just last week I gave a shout out to them for having just a really great group of people up there, and a couple days later Tom sent me this case, and this is a wonderful case that we're going to have a chance to talk about a bunch of things here. Tom was taking care of this, a 79-year-old woman who presented with fairly concerning chest pain. I think everyone would agree that this story is concerning. She had pain at rest, and she also had pain that was radiating to the left arm and jaw. So with the history of hypertension, hyperlipidemia, and that story, we're done. She's being admitted to the hospital. You know what? If a 79-year-old woman comes to my emergency department with just about anything, I'm just going to admit her for a rule out, but well, maybe I'm exaggerating just a little bit, but she's got a concerning story, a couple of concerning risk factors. She's also got a history of breast cancer with radiation treatment in the past. So maybe you're thinking about PE as well as ACS. And of course, she's got gastroesophageal reflux disease, which is a big risk factor for screwing you up. Always be wary of those patients with reflux. And I always say, whenever you write reflux on the chart of somebody you're about to send home, just slap yourself. But she wasn't going home. She's definitely coming in. Now, here's kind of a possible concern here. She said that she was admitted to the hospital a week earlier with pretty much identical symptoms, and her, I think her chart pretty much showed the same type of stuff as well. She got ruled out by troponins. It doesn't appear that there was any stress test. She was simply discharged with the diagnosis of radiation pneumonitis. So how good are those troponins at ruling out ACS? We're going to find out in just a second. Anyway, Tom went ahead and got a 12-lead EKG, and here's the 12-lead EKG. So the machine is calling it normal. What does that mean? It can't be normal, because I would never show you the machine interpretation if it was accurate, right? It's probably a pretty reasonable assumption. Anyway, Tom was concerned about a couple of things here. There's a T-wave inversion in AVL. It's very subtle. There's a little bit of ST depression there as well. Some people might look at lead 3 and say maybe there's a little ST elevation. Gosh, I don't know. If you remember to use the TP segment as your baseline, I don't know if there's really any elevation. Maybe just a quarter millimeter, 0.2341 millimeters. I don't even know. It's just subtle, all right? We'll call it subtle. There's also just a little bit of ST depression in lead V2 and V3, and maybe in V4, and maybe in V5. Wow, you know, that's pretty darn subtle. Are we making something out of nothing? I don't know. The machine's calling it normal again. And so anyway, I'm not really sure what to make of that. He got the old EKG from a week ago when the patient was ruled out based on troponins. Here's the EKG from 1 week ago. And, well, there's a couple differences here. Tell you what, let me take, the similarity there, normal EKG, right? So let's take these two 12-lead EKGs and compare them. So this is 1 week ago, all right, up here, and here's the EKG from now. Let's get rid of all that chicken scratch up there. So this is the baseline, and this is what she's got now. And I think you can appreciate that there's some subtle difference going from AVL to what we've got right now. It looks like she has got a flipped T wave, which is new, and maybe a little bit of ST depression. And I think maybe there's a little bit of ST depression in V2, V3. All right, those have evolved a little bit as well. And V4, maybe a little bit of new ST depression in V4. That is really, really subtle. What do you do with that? Are you going to admit her after she's been ruled out a week ago by the inpatient service? You're going to admit her based on those subtle depressions? Well, remember, the EKG machine's calling this normal, but the EKG machines in general are only programmed to call things positive if there's a full millimeter of change or a full millimeter of ST elevation or a full millimeter of ST depression. If it's half a millimeter or a quarter millimeter, the machine's often going to call it normal, or maybe at most, it might call it just non-specific ST changes. In this case, is calling it pretty much normal. So can a person be having an MI with a 0.5 millimeter of ST change? Of course they can, but your machine is not reliable at picking that up. Now, one other key pearl, who is this guy? This is a very, very famous and incredibly smart guy by the name of Corey Slovis. He's the chairman of the emergency department, full professor at Vanderbilt. And one of the things that he says, and we've talked about his famous quote before, is one EKG or ECG begets another. In other words, have a low threshold for getting serial EKGs. Repeat the EKG, get a second, get a third. It's a piece of paper with ink, for gosh sakes. It costs practically nothing. And if you have any doubt, go ahead and get another 12-lead EKG. And that's exactly what Tom did. So here is what happened. 13 minutes later, he's not waiting. 13 minutes later, Tom gets a repeat EKG, and now, what do you know? The diagnosis becomes just a little bit more obvious, right? Full-blown acute STEMI. And you've got the big-time reciprocal changes in AVL and in V2 and in V3. The person's having an acute inferior wall STEMI, and there's some reciprocal changes. Again, I didn't circle that too well. V2, V3, V4, V5. Of course, with the ST depression out here, you worry about posterior STEMI, and with inferior MIs, you also worry about right ventricular possible extension, whatever. Bottom line is, because Tom got that second EKG, and because he was very appropriately worried about subtle changes in AVL, he repeated the 12-lead and diagnosed the inferior wall MI. Now, this is something that we've talked about before. Let me go back to the EKG that started this whole thing off. When you see a flip T wave in AVL, if that's new compared to the previous EKG, you've got to worry. In a person actively having pain, you've got to worry that that may be the earliest marker of a patient having an inferior wall MI. And that's exactly what Tom was thinking. Okay? Marriott described this many, many years ago. What he said was that when a person has a STEMI or is having a STEMI, the first thing that oftentimes shows up on that 12 lead is not the ST elevation, but the reciprocal changes sometimes precede the ST elevation. And as you recall, when people have inferior wall MIs, the typical reciprocal changes that they develop are very frequently flip T wave and ST depression in AVL. And that was the first thing that showed up in this patient, and then the ST elevation developed later, 13 minutes later. So again, key point here, you've got to know what the reciprocal changes are when people have inferior wall MIs. The first abnormality that shows up in inferior wall STEMIs is oftentimes the reciprocal abnormality in late lead AVL. In other words, the flip T wave, maybe if you're lucky, a little ST depression in AVL, maybe out in V2 also, is the first abnormality that develops in a person with an inferior wall MI. If you're in a cath lab just for kicks and you said, you know what, I'm going to tie off somebody's right coronary artery and see what happens, the first thing that might happen, probably, I'll bet you, is that they flip their T wave in AVL and then develop a little ST depression in AVL and V2, and then a short time later, then they develop the ST elevation in the inferior leads. So remember, key point here is that the first thing that happens in many, many STEMIs is the reciprocal change, and then the ST elevation develops later. By the way, Tom repeated the EKG 3 minutes later, and I want to point one other thing out. All right, it's still an inferior wall STEMI, but you'll notice that the rhythm has changed a little bit. Let me just show you the rhythm strip here, and you'll notice that the patient's got sinus rhythm, and then it goes into clumps. Last week we talked about clumped beats. We talked about the fact that when you see clumps of beats, grouped beats, there's two things you've got to consider: PACs and MOBITs. All right, and this is last week we talked about clumps being attributable to MOBITs. This week, this particular rhythm is attributable to PACs. So there's a PQRS, 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 and then premature atrial complex, and then QRS, and then pause. All right, and then there's another PQRS, and then premature atrial complex, and then pause, and then PQRS, and then premature atrial complex, and then pause. And so the overall result is you get a clump of 2 and a clump of 2 and a clump of 2. So it was just an incidental finding that I thought I would point out. But once again, when you see clumps of beats, go back to last week if you don't know what I'm talking about. But when you see clumps of beats, you think about Mobitz. And this week you recall you think about premature atrial complexes as well. All right. So what was the outcome of this case? Well, Tom didn't waste much time at all. He sent this patient up to the cath lab, and there was a 99% proximal and mid RCA occlusion. I don't know what 99% means. I guess one red cell is getting through that lesion at a time. But anyway, patient got 2 stents, ended up doing well. Okay, so let's sum things up here. Please remember again, the reciprocal changes sometimes are the first thing that develop when a person's having a STEMI, and they can precede the ST elevation. Okay, so when you see things that might be reciprocal changes, what do? Get serial EKGs. Remember Corey Slovis, one EKG begets another. When in doubt, get serial EKGs. And again, going back to the reciprocal change, flip T-waves, T-wave inversions in AVL, in somebody who's having pain, that can be the first marker of their inferior wall STEMI. So get those serial EKGs. Look, I'm going to put an extra check mark there. Okay? Clumped beats, when somebody's got clumps of beats, the 2 things in the differential, at the top of your differential, Mobitz and PACs. And then I just want to highlight one other non-EKG point. Please remember, troponins only rule out infarction. They do not rule out ischemia. They do not, should be a little comma there, they do not rule out ischemia. They do not rule out coronary artery disease. Troponins are only useful at ruling out the infarction. And that's a perfect example in this case where a week ago, the patient had the same symptoms and ruled out by troponins, but they didn't do anything further in terms of stress testing or cath or anything else that would have been more definitive. Now, that's the wrong thing to do. I'm not trying to imply what the standard of care is, but it is important to remember that troponins will not rule out ischemia and will not rule out underlying coronary disease. They only tell you if somebody has actually infarcted. All right, so my thanks to Tom for sending a great case of reciprocal changes in AVL that precede the STEMI, and also a great case where serial EKGs save the day. Thanks again to Tom and all of his colleagues up in London, Ontario, and I look forward to talking to all of you next week. Bye for now.